Good morning, everyone. We have a busy program today, so we're going to get started. Thank you, everyone, for joining today's Library of Congress webinar on influenza and COVID-19. Throughout today's session, we invite you to submit questions for our presenters using the Q&A panel on your screen, and we'll address them in the Q&A segment at the very end of the event. Today's webinar is being recorded and will be made available online. We'll share more information about that before we wrap up today. So with that, to get us started, please welcome the Chief Medical Officer at the Library of Congress, Dr. Sandra Charles.
Good morning. It is really my pleasure to be here today and have you here with us. And I'll get right into it for this webinar, which is a first for us in our health programs. And I just wanted to say that prevention is a core principle of our Occupational Health and Medicine Office in meeting the mission here at the Library of Congress, the world's largest library. We aim to protect and enhance the health and wellness of our staff and their families, prevent the development or progression of injuries or illnesses, including both acute and chronic diseases, through our actions and through education. Education is a tool through which we have consistently encouraged and effected our message of prevention, a message we share not only with our employees, but with our congressional colleagues and the public at large. Last December, just after we had completed our annual fall influenza immunization clinic, we recognized reports of a then unknown virus causing illness primarily in Wuhan, China. We focused on monitoring that illness and began providing alerts and educational pieces in our internal newspaper, the Gazette, in early January. By February, we were receiving reports and providing consultations on travel and quarantining related to the identified agent, SARS-CoV-2, responsible for COVID-19 and the ultimate pandemic. This monitoring and providing of guidance to managers and staff quickly expanded to become our daily focus. We continued our weekly educational updates in the Gazette, and they evolved into weekly messages to all our staff from March until the present. As it became clear that this was a long-haul event and the fall was once again approaching, we considered the potential interactions of COVID and our usual respiratory illnesses, colds, allergies, influenza, pneumonia. The ability to give and receive high-quality education through our seminars and symposia has been a major achievement enhanced by our partnership with my esteemed colleague, Dr. Tomoko Steen, of the Library's Science, Technology, and Business Division. She has been at the ready for us to co-sponsor a number of sessions, and so we initiated discussions on providing an educational seminar on today's topic. As usual, she was able to assemble a remarkable lineup of distinguished speakers for a webinar, as I said, the first in our partnership. It is with pleasure that I turn over the virtual podium to Dr. Steen to introduce our illustrious guest. Thank you for being here. Dr. Steen?
Thank you. Could I have a next slide, please? It's my pleasure to introduce three distinguished speakers. First speaker is Professor Benjamin Gargling. He's a professor and head of the Division of Epidemiology and Biostatistics at the School of Public Health at the University of Hong Kong. He's also co-director of the WHO Collaborating Center for Infectious Disease Epidemiology and Control. So he will discuss international collaborations of disease monitoring and prevention. Second speaker is Professor Sandra Colby. She's associate professor in the Department of Ecology and Evolution at the University of Chicago. Using computational and mathematical models, her group studies how the host adaptive immune response co-evolves with pathogens, especially in ways relevant to epidemiological and evolutionary forecasting, vaccine design, and pathogen diversity. Third speaker is Professor Lucey. He's a clinical professor of medicine at Geisel School of Medicine at Dartmouth University. And he's also research associate in anthropology at the Smithsonian Museum of Natural History, where he is the originator of the 2018 and 2022 exhibit on outbreak, epidemics in connected world. This is a wonderful exhibition. Unfortunately, Smithsonian is closed right now, but I hope everyone can join to see that exhibition once it's open. As a medical doctor, he will summarize what has been reported clinically about patients from China, Europe, and Iran, as well as Australia and South Africa in terms of dual infection with flu and SARS-CoV-2. Before further ado, please join me welcoming virtually Professor Benjamin Colby. Please.
Hello, good morning from Hong Kong, where it's now 11 p.m. I'll just have a few opening remarks about influenza and COVID-19. Next slide, please. The first point I would like to make is that influenza and COVID spread in similar ways. They're both respiratory viruses. They're both transmitted mainly at close contact, when one person who's infected has a close contact with another person who's not, typically a face-to-face contact, or maybe prolonged contact in the same room. And whether it's influenza virus or coronavirus, it will spread in a similar way. Coronavirus is a little bit more transmissible than influenza, it seems. And of course, we don't have immunity to coronavirus like many of us have immunity to influenza. Next slide, please. So when we think about the ways that we will reduce coronavirus transmission in the community, I really like the 3 C's. This is from a World Health Organization poster recommending that people avoid crowded places, avoid close contact settings, and avoid confined and enclosed spaces, particularly with poor ventilation. I think there's a really, really good guideline, but I want to make the point that because COVID-19 and influenza spread in similar ways, these 3 C's, when we apply them, would also prevent influenza transmission. Next slide, please. One of the interesting phenomena about coronavirus and COVID-19 is that there's a super spreading phenomenon where a small minority of infected persons account for the majority of transmission. Certainly that's true in Hong Kong. It's true in some other parts of the world where people have studied it. In the United States, there's not so much data, but I would expect it's quite similar. What that means is if we can limit crowded groups in indoor areas, lots of people together, if we can stop super spreading, we can have an incredible effect in reducing COVID transmission. Let's spend more time outdoors, spend more time with less people around in lower density. But of course, taking the same measures would reduce influenza transmission. Next slide, please. In Hong Kong, where I work, we haven't had any flu for the last 9 months. So we had a winter flu season building up in January and February of 2020, shown in the right-hand side of this slide. And then we brought in some social distancing measures to deal with COVID-19. And those measures worked very well for COVID. They also worked for influenza. And we haven't had any influenza since then. In Hong Kong, we have a special policy of a 14-day quarantine for anyone who arrives in the city if they come in by air from another part of the world. So it's going to be difficult for influenza to come into Hong Kong. And really, we haven't had many introductions of the infection into the city. But even if there was an introduction, I don't think there'd be a much chance for influenza to spread because of the measures that we're still using for COVID. Next slide, please. Globally, it's a very similar picture. So this is data from the World Health Organization, the Global Influenza Surveillance Network. And what we can see from this slide is mostly white across the world, mostly very, very low levels, if any, of influenza. Just some parts of the world still having flu. So flu hasn't disappeared, and that means it will come back to the rest of the world eventually. But I think what's been happening, because we've been doing so much social distancing in many parts of the world, flu just hasn't had a chance to circulate. Next slide. So what do I think we should expect in the coming winter? That means in the next 3 or 4 months in the United States. I really doubt there's going to be widespread transmission with a a nationwide epidemic because of the social distancing measures that are in place because of COVID. But I think there's still a possibility for outbreaks and localized epidemics, maybe in places that aren't doing so much social distancing, for example, or maybe places where the COVID cases are low, so they can relax the measures, and then they'll have a risk of influenza outbreaks at the time when they maybe don't have COVID. But I think if there's some parts of the US that have a lot of COVID about, there'll be a lot of social distancing done, and there won't be so much concern perhaps about influenza spreading at the same time. And of course, the social distancing measures that are in place right now are likely to be in place more or less for the next 3 to 6 months. Sometimes they'll be more stringent, sometimes they'll be relaxed. Vaccines are coming. We're going to start vaccinating very, very soon, but it's going to take time to get people vaccinated before we can think about getting back to normal. And then the last point I want to make is that if we don't have widespread influenza transmission this winter in the US, that's going to lead to a drop in population immunity. And that means that next year, there'll be maybe more people vulnerable to flu than there would otherwise have been, and maybe a risk of a larger epidemic next year, more so than I would say this winter. And so I think we can think about that and worry about that a little bit later, probably recommend vaccination next year particularly, but still, of course, recommend vaccination this winter. That's it for me.
Next speaker is Professor Sarah Colby.
Hi. So I'm going to pick up where Ben left off on the fact that we haven't seen much influenza. In this case, I'm going to focus on the United States. Next slide, please. So what we're looking at on the left are curves of influenza-like illness for multiple flu seasons. So the gray curve that you see shows the influenza-like illness curve for the 2009 H1N1 pandemic. The red curve at the bottom left that you see with red triangles is showing ILI for this season. And then the other colored curves are influenza-like illness for the past few flu seasons. So what you can see, again, just reinforces what Ben was explaining to us, which is that there's not much activity right now. And I think this is particularly striking because, again, there's quite some overlap between the symptoms of COVID-19 and influenza. So if you shift to the curve on the right, you can see, again, more evidence for what I'm describing. So what we're looking at here, the left axis is showing the number of influenza positive specimens that are obtained by U.S. clinical laboratories that report to the CDC. And then we have the percent positive of all specimens tested on the right. And so we still have well under 1% of influenza-like illness specimens testing positive for flu, and we're not seeing the increase in positive specimens that we would normally be expecting this time of year. And then the last piece of evidence that I'm going to present, next slide please, I think is the most striking and is something that Grandma has drawn attention to, which is that we haven't seen any influenza deaths among children so far this season in the United States. And I'm showing you here several recent seasons. Normally, we would have expected to see some by now. All right, so again, we see that probably many of the measures that we're taking against COVID-19 are effective also against influenza, but I want to actually draw your attention to a broader pattern that these curves have implied. Next slide, please. So it's that when we're looking at curves of influenza-like illness, we should actually keep in mind that most of that illness is not really caused by influenza. So what you're seeing on the right here, I just picked it's not really a random season, but I picked 2018-2019, which is a very typical season in the sense that when you look at the peak of flu cases, which occurred in this case like in February, what you see is that it's still only, up to, like in this case, 25%, other seasons might be 30% of all influenza-like illnesses are being presented to outpatient, in outpatient settings. So what this means is that most influenza-like illness is not actually caused by flu. And this is something that's been shown in a lot of settings, including Ben Kelling has done some work on this in Hong Kong. So what is it? Well, some of the specimens usually don't yield a clear signal of viral etiology, but plenty of them do, and plenty of them are showing that it's really non-influenza viruses that are causing these flu-like symptoms. Next slide. So I've presented an incomplete list here of many of the viruses that are commonly identified in these ILI cases. You have adenoviruses, parainfluenza viruses, respiratory syncytial virus or RSV, rhinoviruses, which we often think of as like the cold viruses along with seasonal coronaviruses, Bocavirus, which was only discovered in the last 20 years, human metapneumovirus. There are all these other things that are out there that are circulating and that are contributing to our measure of influenza-like illness. And I've put in bold two of the viruses that are particularly associated with mortality. RSV causes mortality in infants, but also in the elderly, as does parainfluenza virus. And, you know, it's difficult right now, I think, to describe or to characterize the circulation of these different respiratory pathogens with much precision. There are a lot of studies that look at, okay, so what are people with flu-like illness actually infected with? And I'm showing some observations from France in the fall of 2009 on the right. But I think the overarching lesson is that the precise viruses that are contributing to influenza-like illness, it varies a lot in space. It varies depending on which age group you're looking at. It varies by time of year, and it also varies by year. So here you can see, for instance, we do have influenza H1N1, which was the pandemic strain infecting younger people disproportionately, but also, you know, in the 1 to 14 age group, there's really quite a diversity of pathogens there. So what we're seeing then is really a strong suggestion that the measures we're taking against COVID-19 are effective not only against flu and reducing flu transmission, but they're also probably impacting the transmission of all of these other pathogens that contribute to influenza-like illness. Now, unfortunately, we don't have such systematic surveillance in the United States for these other pathogens, but I'm going to show you a little bit of data in the next slide for respiratory syncytial virus. So you can see the percent of specimens testing positive for RSV. There are different tests that you can do to look for RSV. On the left, you can see that they've all been, you know, declining sharply since the emergence of COVID. But, you know, you can also, with percent positive, you always have to worry about the denominators, the number of tests increasing a lot. You know, is that why the percent positive is so low? But no, we're actually really not detecting much RSV right now in the population. So again, this is evidence that these measures against COVID are really having a broader impact on the transmission of respiratory pathogens. Next slide, please. So I want to talk a little bit more about what we might expect this winter. I think there's some uncertainty about how much vaccination against COVID there's going to be in the United States. And so I'm just, you know, kind of laying out a hypothetical here. So, you know, if there is widespread vaccination this winter, it's possible that's going to lead to a huge reduction in the non-pharmaceutical interventions, so the social physical distancing and mask wearing, which I expect would lead to surges in influenza-like illness. Again, it is happening in the winter. And again, a lot of that influenza-like illness is not going to be flu. And I haven't mentioned this, but a lot of these pathogens primarily infect children. And so we especially might see an increase in influenza-like illness in children, or that's clearly associated with the reopening of schools. And another point that I'd like to end on is that, of course, vaccination coverage is highly uneven across the population. I'm showing here a figure with the average coverage by state. So Nevada is at one extreme. It's estimated that 44% of the population that year, but at the other end. But of course, there's also enormous variation within populations, and a lot of that variation is racial and ethnic. And I think it's an open question whether we're going to see correlations between COVID-19 vaccination uptake or coverage and seasonal flu vaccination rates. So next slide, please. And I think this is particularly important because one of the, you know, really obvious lessons from watching the COVID-19 pandemic in the United States is that there are enormous disparities, sociodemographic disparities, especially associated with race and ethnicity, but not only associated with race and ethnicity, that have been driving and deaths, you know, different segments of the population. And frankly, this is something too that, you know, there's been emerging evidence for in the context of influenza. What we're looking at here are the hospitalization rates for flu, race and ethnicity, but there's also clear associations with poverty of race and ethnicity. So I am concerned that this winter could exacerbate health disparity owing to other respiratory pathogens if there is potentially by the COVID-19 these measures that have been suppressing transmission. Thank you.
Okay, next speaker is Dr. Lucey.
I'd like to briefly add a few slides to what Ben and Sarah have already presented before we go to questions from the audience. Next slide, please. I'd like to talk about the clinical impact of co-infection or dual infection, simultaneous infection with both the SARS coronavirus 2 that causes COVID-19 and influenza viruses, whether influenza A or influenza B. There's been a limited number of reports about large numbers of people having co-infection with SARS coronavirus 2 and with an influenza virus. I think in large part because of what Professor Colby and Professor Gargling have already said, that there's been a striking decrease in a number of influenza cases in places where there's been the epidemic or the pandemic of COVID-19 due to SARS coronavirus 2. There's been a number of case reports, small series, but really the largest published report that I've seen, and this is actually still a preprint, is from the United Kingdom, from Public Health England, by Julia Stowe et al. And this is a figure from their paper, and what it shows is on the x-axis on the bottom is the calendar week, so starting in January of 2020, this winter. And the blue colored bars are SARS coronavirus 2, laboratory confirmed infections, and laboratory confirmed negative for influenza. So you can see the great majority of the people who have infection have COVID-19, have SARS coronavirus 2, but not influenza viruses, A or B. Then the next bar is sort of a light green color, and that refers to people that are laboratory positive for influenza virus, whether it's A or B or H3N2 or H1N1, influenza A or any of the influenza Bs. And they're also negative for SARS coronavirus 2. And as you can see, the green bars are much smaller, representing many fewer people than the blue bars. And finally, it's difficult to see, but the red color are people that have co-infection with SARS coronavirus 2 and an influenza virus. And because of the scale of the y-axis, the red bars are very small, and you can see when they occurred there during the calendar week of 2020. So we have a limited number of people who have co-infection or who have been laboratory confirmed to have co-infection with SARS coronavirus 2 and influenza virus. Next slide, please. So this particular study from Public Health England, PHE, that was really a study of what I'm focusing on here in terms of clinical impact of co-infection with SARS coronavirus 2 and influenza virus. The specific data that I would like to emphasize, 3 bullet points you can see here. Basically, they had a total of 58 patients who had a co-infection with SARS coronavirus 2 and influenza. And of those 58, 32 or 55% were greater than or equal to 70 years of age. I think that's an important point that I'll refer back to, and in particular, I think echoes something that Professor Colby just said. So basically, the data that we have here is primarily in older people, and particularly greater than or equal to 70 years of age, in terms of the emphasis on the conclusion that co-infection causes worse disease than infection with SARS coronavirus 2 alone or with an influenza virus alone, including influenza A, H3N2, which usually causes the most severe influenza disease. So of these 58 patients with a co-infection, there was a risk of death that was quite elevated, 5.92, with the 95% confidence intervals from 3.2 to 10.9. So this risk of death was increased among those with dual infection or co-infection as compared with those who had neither influenza nor SARS coronavirus 2, and a risk of death of 2.27, greater than if you had just COVID alone. So it suggests, the authors conclude, that there might be a synergistic effect between the two viruses, SARS coronavirus 2 and influenza virus infection. But I'd like to emphasize again that more than half of the patients, 32 of the 58, were 70 years of age or older, where we know in general there's a markedly increased risk of severe disease, hospitalization, intensive care, and death, whether you have COVID or influenza infections in general. And the last point I want to emphasize from this study is that the authors concluded that the risk or the odds of ventilator use or death, an intensive care unit or ICU admission or death, was greatest among people who had co-infection with SARS coronavirus 2 and influenza. And they conclude that this is strong evidence of an interaction effect compared to either independent infection with just the SARS coronavirus 2 or just influenza virus. Next slide, please. Just to summarize and offer some references to a few other reports in the literature, most of which are quite limited. There may be a report of an individual patient or of a small series of patients, for example, in the US and Louisiana, or from Spain, or there's individual case reports from Iran, as well as the larger one that I mentioned here. And similarly, there were other reports from the Southern Hemisphere that I'll just summarize. There have been, in my view, a really incredible and admirable number of publications in the medical literature from China in general, but particularly from Wuhan and Hubei province about COVID-19. But this particular study that I'm referencing here in the Journal of Medical Virology this year concluded that people who had both COVID-19, that is the SARS coronavirus 2 infection, and an influenza virus infection, they overall had a worse clinical outcome than people who had just one virus infection or the other. Similarly, in Iran, in addition to individual case reports, there is a publication also in the Journal of Medical Virology that came out the 28th of July, which concluded that in the northeast of Iran, that there was a high prevalence of SARS coronavirus 2 and influenza A, particularly the H1N1 pandemic 2009 influenza virus, that there was an increased prevalence of co-infections in patients who had died this year in northeastern Iran. With regard to the Southern Hemisphere, such as South America, Southern Africa, Australia, New Zealand, Indonesia, and other locations in Asia, there have been really few reported co-infections during this 2020 winter. And I think that's for the reasons that Professor Cowling and Professor Colby have already mentioned in terms of the dramatic decline and dramatic decreased incidence of influenza virus during this year of the COVID pandemic 2020. Next slide. So in terms of summarizing the four key messages that I'd like to emphasize, some of which have already been emphasized by Ben and Sarah. First of all, co-infection with SARS coronavirus 2 and influenza is not common at all. In fact, it's very unusual this year in 2020. However, what we can learn from the literature, from what I've been able to find, is that overall there's a more serious risk of clinical medical disease and risk of death, although the numbers that have been reported are small. So I'd say that this information emphasizes the importance of getting an influenza vaccine, and I would say doing it now before influenza if it's going to happen before it occurs in the United States at least. And I would say also, in my opinion, another good reason to get the influenza vaccine now is so that when you get the COVID vaccine, which will be in the winter or spring, that there's no issues about having gotten both a flu vaccine and a COVID vaccine within a couple of weeks of each other, so that there will be really no possibility of an interaction in terms of adverse events, in terms of whether it's fever or muscle aches or sore arm or potentially more systemic effects of the vaccine. Also, I'd say this information emphasizes the importance of testing, laboratory testing, for both SARS coronavirus 2 and influenza virus, because the symptoms can overlap, as well as with other non-influenza and non-SARS coronavirus 2 virus infections that Sarah mentioned. There's a relatively long list of other viruses and even non-viral causes of influenza-like illness. Also, in terms of treatment, there are more antiviral drugs approved by the US FDA and available to treat influenza and potentially to prevent influenza virus infections than there are currently for SARS coronavirus 2. So knowing which virus infection you have, or if you have both, would increase the treatment options. So I'd like to thank everyone for allowing me to give this presentation, and I'll stop here.
Thank you very much. So we will read the questions first.
Thanks, everyone. So the first question today reads, everything I've read about COVID-19 transmission suggests there is a very low chance of transmission via contact with services, but every study seems to end with keep washing your hands after touching anything. This seems contradictory. Do we still need to be careful with our groceries and packages?
Can anyone answer the question, panelists?
Yeah, this is Ben Cowling. It's true there's very limited evidence that COVID spreads through surfaces, through contamination in the environment, but it is a possibility, and we know that coronaviruses can infect the intestinal tract as well, the digestive tract, not only the respiratory tract. And there are some case reports where there might have been a transmission through that process, but in general, I think we understand most COVID transmission is from prolonged close contact with infected people, typically in the same room for a longer period of time, also without wearing a mask or without having other precautions in place. So I don't think it's necessary to quarantine your groceries. It's of course always a good idea to wash your hands for many different reasons, not necessarily for COVID, but for many different reasons.
Thank you. So next question.
How useful was the SIR model during the 1957 Asian flu?
Sarah, would you answer?
Sure, I can take a stab at that. So for those unfamiliar with modeling jargon, SIR stands for susceptible, infected, and recovered. And it basically assumes what the name implies, which is that you can distinguish the host population by its status with respect to viral infection. So I haven't seen many SIR models of the 1957 pandemic, which is the emergence of H2N2, which had displaced the preceding strain, which was H1N1. But I can certainly talk about what we know now, I think, would influence those kinds of models. So the two major challenges we have in modeling, I'd say flu mostly, are first, we don't understand how seasonality works very well. So we don't understand exactly why transmission rates are higher in the winter. If a new strain emerges, for instance, in the spring, how long it's going to spread before dying out for the summer and then, reemerging in the fall. So that is not in a plain vanilla SIR model. It's something that needs to be added and something that we still struggle with. The other complication, I would say, with using one of these simple models to understand the early dynamics of H2N2 is that we know there is actually a lot of, we call it cross immunity. So in this case, it's, your immune response to one influenza strain that, again, might have a different name like H1N1, which means it has pretty different surface proteins, can actually be quite effective, not totally prevent infection, but still, attenuate infection, probably attenuate transmission. And that sort of cross protection, I think we're really still kind of wrapping our heads around what, how powerful it is and, how it affects dynamics between strains. So I think actually modeling the emergence of H2N2 is probably, it's a lot harder than modeling the emergence of COVID-19 because we know there's a lot of cross immunity between flu strains. The epidemiology problem is definitely real for both pathogens.
Dr. Colby, do you have something to add?
Not for that question.
Yeah. Okay. Thank you. Next question, please.
If you had the virus and have antibodies, can you still be vaccinated?
Anyone can answer this question?
Yeah, this is Ben. Yeah, I think it would be a good idea for people to choose to get vaccinated, whether or not they've had a previous infection, even whether or not they know they've got antibodies in their blood. The vaccine's still going to give a boost to immunity, and we don't know how long the natural immunity lasts for after an infection. So I think it would be a good idea for everybody to get the COVID vaccine once it's available for people to get. I don't think people who've been infected before should necessarily avoid vaccination.
Thank you. Next question.
I could add one thing, Dr. Steen.
Yeah.
This is Dan Lucey. The planned U.S. vaccination program, at least preliminarily, because there hasn't been a vaccine that's gotten emergency use authorization yet, but the FDA committee will meet on December 10th. What I've seen, it states that there's really no necessity and no role and no plan to test for antibodies in people before they get the vaccine. I think that's consistent with what Professor Gargling just said. So if you have antibodies, it's fine for you to get the vaccine, and I would agree with Ben that hopefully getting the vaccine would increase protective antibodies, so-called neutralizing antibodies, which the conventional test in the United States, at least for antibodies, if you've had an infection with the virus, that test is not necessarily specific for neutralizing antibodies, which is what the vaccine should induce primarily. So I think that's a long way of saying yes, you still can get the vaccine.
Great. Thank you so much. Next question, please.
Can you discuss the long-term effects of COVID for people who had it that are just starting to be revealed now?
Can somebody answer this? Maybe Dr. Lucey? Yeah.
Yeah, just briefly, I'll start, and I imagine Sarah Ben might want to add something, but there's a number of terms that have been given to people who have symptoms that generally, at least in the U.S., said to be 3 weeks or longer. So some people call it long COVID. Earlier, there was a term called long haulers, which personally I don't like that term so much, but it reminds me of a truck or something. But long COVID, there was one paper in the Journal of the American Medical Association, October the 5th, by Dr. Carlos Del Rio from Emory University in Atlanta and others that used the phrase that I haven't heard otherwise before or after chronic COVID. Personally, I don't really like that term either, chronic COVID, because it's not clear to me that there is such an entity as a chronic, meaning months or years. So I like the term long COVID. So there are at least 3 major parts of the body that are affected. One being the brain, which will include our sense of smell and taste, but also it seems a sense of clarity of thought, if you will, or the loss of the clarity of thought. Some people use the word fog, brain fog. Again, that's not a particularly medical term or one that I like. The second part of the body that's often involved with long COVID is the lungs. So you can develop breathing problems, particularly when you exert yourself, exercise, or even walking or walking upstairs. Sometimes scarring of the lungs can occur, and that can be responsible for the long-term meaning more than 3 weeks, lung symptoms. And then the heart can also be involved with symptoms in terms of the heart basically not being able to function as well as normally, which can also contribute to shortness of breath. In addition, I have just anecdotally some friends from the medical profession, including from medical school a long time ago, that had long COVID, and one of them told me that she had a fever for 43 days, which makes you wonder about what the cause of that is, as well as the cause of long COVID in general, whether it's due to the virus itself, SARS-CoV-2, or an inflammatory cascade, if you will, that was triggered by the virus, but then is maintained by what I would call an abnormal or a dysregulation of the immune system, rather than the virus itself. So I'll stop there.
Dr. Gargling or Dr. Colby, do you have something to add?
No,
just very briefly, my understanding is we don't understand how frequent this long COVID is, whether it's 1 in 10 infections, 1 in 100 infections, 1 in 1,000 infections. We know it occurs. We know there's a lot of people with long COVID, but there's also really a lot of people who've had COVID infection. And I think that's one of the uncertainties that we'd really like to get a handle on. How frequent is this syndrome, and what are really the full characteristics? Over.
Thank you. Dr. Colby?
No, I have nothing to add. That was great.
Okay.
Tomoko, sorry, could I just add one more thing about the smell, sense of smell, because it's really quite striking. The sense of smell, it can be lost altogether, or it can simply be abnormal, including with long COVID, where the sense of smell may come back, but it may be sort of mistaken or erroneous smells. So if normally you smell green grass, now you might smell when you're out in the yard with green grass, instead of smelling the green grass, you might smell something very, very different. I don't know, like the ocean spray at a beach, just as an example, or something much worse than that. So some people have really, really unpleasant or worse than unpleasant smells that are not verifiable in terms of the environment. There's no such smell that should be objectively present, even though you smell a certain thing. It's very, very psychologically disturbing to some people to have this sort of erroneous sense of smell.
Yeah, so UK has a government branch to take care of these people. So I guess Ben is familiar with that too. So next question, please.
Flu season tends to overlap with the colder weather months in the United States. Is there any connection between lower flu and the warmer weather we've been experiencing?
Ben or
yeah.
So
Sarah's probably the best person. Okay.
We can both talk. You start.
Yeah. Okay. So influenza does have a seasonal pattern. It prefers to spread in the winter, in the really cold months, compared to in the spring or the summer. But that's not always the case. So in Florida, actually, they do have flu seasons that extend into the spring or start earlier in the autumn. And I think this year, particularly because if we don't have a winter flu season, it's quite possible there could be a late season, like a spring season instead, just because we've missed the winter season and there is still an opportunity for it to spread. I don't think the warm weather recently has made that much difference. It's really the social distancing that's made the difference, that in stopping flu from spreading. Over.
Sarah?
Yeah, I think that's roughly right. I mean, there's something that is driving a lot of respiratory viral transmission in the winter that, again, we still don't completely understand. And in my group, we've actually been looking for an association between increases in humidity and, the warmer weather that's associated with that, and subtle changes in the reproductive number of COVID-19 in Illinois. And we're really not seeing much of an association. And I wouldn't expect the seasonal drivers at this point to vary too much, between these respiratory pathogens. So I think we're not seeing flu, again, because the measures we're taking against COVID-19 are really effective against flu too. And flu is just not as successful, a pathogen as COVID-19 is right now. It's just not got the same sort of population of susceptible hosts available to it. So it's effectively just being pummeled, by the measures that are in some ways less effective against COVID.
Of course, both of you know about the transmission rate differences between flu and COVID. So that might be, competing those two infections, I guess. Thank you. Yeah. So.
Sorry, go on.
Yeah. Thank you. And next question, please.
Okay, so we know that COVID-19 is a respiratory disease. Is there any possibility of COVID-19 infection due to blood transfusion?
Ben, please.
No, I don't think so. I mean, Dr. Lucey might have a good answer. I don't think so.
Dr. Lucey, do you have a comment?
Short answer is no. But I think it's important to offer some support evidence. I think that from the really beginning of the recognition of the outbreak and then the epidemic and the pandemic of COVID-19, I'm sure multiple places in the world, but certainly in the U.S., the FDA and the blood banking community has been looking for evidence of the virus in the blood, and in general, or almost always, we don't find the virus in the blood, so it wouldn't be transmitted through blood or blood products, platelets or other transfusion products. And I would say that as a result, that's why we do the nasal or throat or nasopharyngeal swabs or testing rather than testing blood. When you see studies of the blood, for example, it came out this week, 2 days ago, 2 days ago, a report that maybe there had been patients in the United States since mid-December, December 13th going forward, in a study of stored blood samples from 9 different states, mostly from the northern tier of the United States, from the northeast to the north central to the northwest. For some reason, not in the south, those samples weren't tested. But that was based on antibody tests. So in the blood is where you find the antibody, but for this particular virus, SARS coronavirus 2, you don't find it in the blood as a general rule. Back to you.
Already mentioned that the gastro impact is, so fecal sample study is already done. Blood is, I think nobody has done it. Thank you so much. Next question, please.
What is the status of research into melatonin and vitamin D3 and perhaps preventing or lessening COVID infection? And would findings from that research pertain to influenza also?
There's actually been quite a lot.
Oh, yeah.
There's been quite a lot of research on vitamin D and influenza. It's kind of mixed results. The randomized trials that have been done don't tend to show an effect in preventing influenza. There is going to be a confounding in some of the other studies that are done because people who spend more time outdoors may have higher levels of vitamin D in their blood because they've spent more time outdoors. And then because they've spent more time outdoors, they've also got lower risk of flu because it mostly spreads indoors. For melatonin, I'm not aware of really very much research at all. For COVID-19, I think it's too early for people to be able to look at those kind of things. There's an interesting hypothesis about vitamin D and maybe some other supplements that might have a minor effect in changing the risk of COVID, but I don't think any of those dietary supplements would have a major effect on risk of COVID. That would be my assessment.
Thank you. Dr. Lucey or Dr. Colby, do you have any? Yeah.
Yes, this is Dan Lucey. I would agree with Ben, although there's been a lot of discussion in social media and elsewhere with regard to COVID and potential value of supplements, dietary supplements has been said, particularly vitamin D, but also the other big one in the U.S. at least is zinc, which has a fairly long history of several decades that I'm aware of being touted, if you will, as beneficial during the winter influenza season, whether it's specifically for influenza virus or other viruses. But again, to my knowledge, there's not been any type of randomized controlled trial that corroborates the value of zinc, either for influenza viruses or for SARS coronavirus 2. And similarly, to my knowledge, for vitamin D. I mean, if you have a vitamin D deficiency, that's one thing. But if you don't, to my knowledge, there's no solid medical evidence or epidemiological evidence of a benefit of taking supplements of vitamin D or zinc, or there are a list of others like selenium and quite a few others. But to my knowledge, none have been shown rigorously to be of benefit for SARS coronavirus 2 COVID.
Thank you. Next question, please.
Do we have any idea if dual infection raises the chance for long COVID?
That's a good question.
That's a fascinating question, and I have not come across any evidence to support that. But also, it hasn't been studied, to my knowledge, in any rigorous way. But that's something that I think should be, and hopefully is planned to be, and it's something that again I appreciate the question because I hadn't thought of it myself, and it's something I'll go back and look at and to see if it's being done now in studies prospectively as we approach, or as we're entering into the season for influenza, other viruses like Sarah said, and SARS coronavirus 2.
Dr. Gargling or Dr. Colby, do you have any comments? Maybe your future research.
No.
No? Okay. Thank you so much. Next question, please.
As we're still learning how to live with SARS-CoV-2, are there techniques or tools that we know are definitely not effective with the influenza virus?
Sarah? That's a really fun question. So, yeah, I would say really a lot of it's been, a lot of it's about what Ben just mentioned, which is that so much transmission we know occurs indoors. And so probably focusing on hand washing at the expense of air exchange rates and the number of people, who are crowding indoors it would be a mistake. Clearly, I'm saying we now in the United States have learned a lot from the experiences in East and Southeast Asia, their experiences specifically, not just with flu, but with SARS and MERS on the role of mask wearing. That's something that Ben can definitely speak more to. I'd say one interesting way in which SARS-CoV-2 seems to be departing from our traditional, kind of flu story is that children right now do not appear to be the main drivers of transmission, with SARS-CoV-2 in the way that they do for influenza. So that's, that's interesting. It's effectively putting more of the burden, on the adult population to behave responsibly rather than just to, vaccinate the children.
Dr. Gargling, you have anything to add?
No, I mean, masks is something worth saying a little bit more about. So we've known for a while that masks should work. We just haven't really understood how well they work. And now I think there's a lot of debate in the US for sure about whether masks are really needed or not. And it is really very clear masks help, but it's also very clear that masks are not perfect. We can't expect masks alone to stop COVID from spreading. We know that's not the case. We have to avoid expecting miracles from masks. So we know that masks can help, but at the same time, we're also going to need other measures in place. And I think we might see masks being more accepted in future years. Maybe if there's a bad flu season like there was in 2015 in the US, in another bad flu season in the future, maybe we'll think about wearing masks during that period of time as well to reduce transmission. Now we've had all this experience with COVID-19.
So if I can add, the viral load isn't a mask or gargling that helps by doing it. The viral load? Yeah,
it's not clear whether gargling is a good treatment for certainly for COVID-19, whether it could really reduce risk. Because after you get infected, the virus actually spreads in your respiratory tract, so it's not just in your throat. So gargling could have a disinfectant effect in the throat, but there's virus plenty of other places in your respiratory tract, in the thorax, and maybe in your nasal passages as well. So I'm not sure about that.
Okay, thank you. Next question, please.
If the measures in place to prevent COVID-19 transmission have resulted in dramatically less flu, could you speak to why COVID-19 is continuing to spread in the U.S. at such alarming rates?
Yeah, it's because COVID spreads more than flu. It's more transmissible, either because people who have COVID are more contagious than people who have flu, or maybe because we don't have immunity against COVID, whereas most of us do have some degree of immunity against flu. And of course, many people are vaccinated against flu. So it may be a combination of things, but COVID is spreading more than flu would spread. It's more transmissible, I think would be the summary.
Yeah, very good. Straight answer. Thank you. Next question.
Is it possible that we could experience a late flu season in the spring or into the summer if people start returning to work and school after a coronavirus vaccine is more widely available?
That's for everyone.
I'd say definitely, and I would worry about that through at least May, which is why we see, when H1N1, H2N2, H3N2, we often see these new strains emerging because they're really transmissible much later in the spring or later in the winter than we normally expect. So I think that's a risk here.
Dr. Colby, anything to add?
Nope.
No, thank you. So next question, maybe last question.
Okay. Do people already on anticoagulant regimens have a better outcome if they become infected with COVID?
That's a good question. Dr. Lucey, maybe?
Yes, so the theory behind the question is because we know that SARS coronavirus 2 infection can trigger clotting, coagulation pathway disorders, so you can develop multiple or many blood clots, whether in the lungs or in other parts of the body that can be life-threatening. And so in many places, including the United States, anticoagulation therapy is given to patients who have SARS coronavirus 2, particularly if they're quite ill or in the hospital. So a number of people are on some level of anticoagulants, for example, one aspirin a day, or other more intense anticoagulation for other reasons for years or months prior to COVID. So it would sound reasonable, a hypothesis that they might have a lower risk of clotting if they get SARS coronavirus 2 infection. But I'm not aware of any published results about that. I think that there probably are prospective studies going on to try to answer this question, but I'm not aware of any conclusive publications at this time to say whether or not anticoagulations or pre-existing SARS coronavirus 2 infection is beneficial or not. But it would be very important to subdivide the anticoagulation into what type. Is it, very comprehensive with anticoagulation, or is it just one aspirin a day, for example? So back to you.
Thank you so much. Within 1 hour, we covered quite a bit of the questions. And thank you so much for all the wonderful presentations. If you could not, get the answer from your questions, there is a place you can send in, and I can pass on to the speakers, or we can do research. So please send in Ask a Librarian question. And also this video is going to be uploaded, and 2 different places you can see. So we have usual Science and Technology and Business Division have the webcast LibGuide, and also we are going to add that, as well as Library of Congress YouTube page. And if you have any other questions, specific question, also you can reach us, Dr. Sandra Charles or me. So thank you so much for attending for this very informative event.
Thank you.
Thank you so much.
Thank you.
Thank you, Dr. Steen. Bye-bye.